Okay, so good evening, everyone, and welcome to Physiology. 25 most important questions for the upcoming FMG exam. So, कैसी चल रही है आप सबकी पढ़ाई? Hopefully, it must be on track. Hopefully, you would be revising every day, putting in your efforts. Exam is not very far away, and therefore, the importance of these 25 most important questions. They're not just questions, they're 25 most important topics in physiology. I will try and cover up maximum number of questions which have been asked from these topics. So let's start, right? Good evening, Dhanashri. Good evening, Shreya, Sunny, Himalayan 986. Good evening. All right. So let's take the first thing. Now, first, there's a little piece of gyan for you, and that is that every day does not need to be perfect, but consistency. Consistency is the key. Just be consistent. Every day you have to show up. Show up. That means every day put in that effort which is required. Right? It does not have to be a perfect day. It is not possible. Sometimes we make targets for ourselves every day, and those targets are not getting fulfilled. Don't be too harsh on yourself. Be kind to yourself. But the important thing is show up every day. Right, let's take on our first topic. Now, this is the LV pressure volume loop, right? The LV pressure volume loop. Now, this was asked even in the 2026 exam, the January 2026 exam, and that is your left ventricular pressure volume loop. Now, here it says, what does the point B indicate? Now, as far as this question is concerned, what does this point B indicate? Now, this is actually at the end of the isovolumetric contraction phase, and this means it is the opening of the aortic valve, right? Opening of the aortic valve. A to B is what is known as isovolumetric contraction phase. B to C is the ejection phase. A to C is systole. I'll just draw this LV pressure volume loop for you, and let's try and understand this. Now, for the LV pressure volume loop, we take the LV volume on the x-axis, this is in milliliters, and the LV pressure in millimeters of mercury is taken on the y-axis, right? So this is 50, 100 and 120, and LV pressure varies between 120 and 0, right? So 40, 80 and 120. Right? So this is the LV pressure on the y-axis, right? Now, at the end of diastole, what is diastole? Diastole is a period of filling. The ventricle is filled with blood. The volume of the left ventricle is at 120 ml and the pressure is at 5 millimeters of mercury. So this is my point A of the loop. LV pressure is at 5. It's filled with blood. Diastole, it's the end of diastole. It's filled with blood and the pressure is at 5. Now, if I just draw the LV left ventricle, left side of the heart for you, this is the left atrium. The mitral valve was open, filling was occurring during diastole. During diastole, the aortic valve is closed, right? Filling was occurring during diastole. Now, at the end of diastole, the volume is 120 ml and the pressure is 5. This pressure of 5 millimeters of mercury is higher than the LA pressure. LV pressure is more than the LA pressure, so this causes the mitral valve to close, right? So at this point, I have the closure of the mitral valve, and closure of the mitral valve produces which heart sound? And that is going to be the first heart sound. First heart sound means end of diastole, beginning of systole. Now, as you can see over here, the aortic valve is closed, mitral valve is closed, left ventricle is a closed chamber. It begins to contract. Now, there is going to be a sharp rise in pressure. The pressure will increase from 5 and go right up to 80 millimeters of mercury with no change in volume. This is known as the isovolumetric contraction phase. Isovolumetric contraction. Huge increase in the LV pressure with no change in LV volume. At the end of this phase, now the LV pressure becomes more than the aortic pressure. Aortic pressure at this point is at 80. Aortic pressure is 120 by 80. So this is the diastolic blood pressure of the aorta, which is at 80. As soon as the LV exceeds the diastolic blood pressure, it causes the aortic valve to open. So aortic valve opens and you get now the onset of what is known as the ejection phase. In the ejection phase, there is going to be increase in the LV pressure to 120 and there is a decrease in LV volume. Then we find there is also a fall in the LV pressure till it reaches point C. So this was B. At A, first heart sound, this is due to closure of the mitral valve. Mitral valve closes, producing the first heart sound. At B, the aortic valve opens. And B to C is the ejection phase. At point C, as soon as the LV pressure becomes lower than the aortic pressure, the aortic valve will close. And closure of the aortic valve will now produce what is known as the second heart sound. Aortic valve closes and you get the second heart sound. End of systole. Between S1 and S2 is systole. Between S2 and the next S1 is diastole. Now, again, aortic valve is closed, mitral valve is still closed, left ventricle is a closed chamber, there is going to be a sharp fall in pressure with no change in volume. This is known as the isovolumetric relaxation phase. It reaches point D. At point D, now the pressure is 0, lower than the LA pressure. This now causes the mitral valve to open and blood starts going from the LA to the LV, giving rise to what is known as the filling phase. In the filling phase, the LV volume will increase from 50 to 120, pressure increases from 0 to 5, right? Very slight increase in pressure in spite of a larger change in volume. This is because the left ventricle is a compliant chamber. Ventricles are compliant chambers. What is compliance? That means these ventricles can distend. You know, it is like when you're filling a balloon with water. जब आप एक गुब्बारे में पानी डालते हैं तो वो expand कर जाता है ना? So pressure अगर expand करेगा तो pressure में increase उतना नहीं होगा. So there is only a slight increase in pressure from 0 to 5. This is known as the filling phase. At the end of the filling phase, volume is at 120, pressure at 5, more than the LA pressure. Mitral valve closes, first heart sound, and now starts the next cardiac cycle. So please remember, A to B, isovolumetric contraction, B to C, ejection phase, C to D will be isovolumetric relaxation, D to A is the filling phase. What is the width of the loop equal to? The width of the loop is equal to the stroke volume. What is stroke volume? Volume of blood ejected per ventricle per beat. That is the stroke volume. Normal stroke volume 120 minus 50, that is about 70 ml. You can also calculate what is known as the ejection fraction. What is ejection fraction? Ejection fraction is the stroke volume divided by the end diastolic volume. I've just calculated the stroke volume for you, width of the loop. So this is 70 ml. End diastolic volume at the end of diastole, LV volume is 120 ml. When you divide this, you get an answer of approximately 0.6. Normal range is 0.55 to 0.65. What does this mean? What is ejection fraction? Ejection fraction means how much of the blood present in the ventricle is ejected in one beat. So about 60% of the blood in the ventricle is ejected in a single beat. That is stroke volume divided by the end diastolic volume. And to remember which valve opens and closes at which point, there is a little acronym for it, and that is, you have to remember your physio ma'am. So ma'am, Coco. At point A, mitral valve closes, producing the first heart sound. At point B, aortic valve opens. At point C, aortic valve closes, producing the second heart sound. At point D, mitral valve opens. And this is the exact question which came in the January exam. So we've revised the LV pressure volume loop. An important topic as far as your exam is concerned. Now, next important question, second messengers. Very, very important, has been asked quite a few times. And which of the following hormones uses cyclic GMP as the second messenger? You know, the second messenger can be cyclic AMP, cyclic GMP, inositol triphosphate, it can be diacylglycerol, nitric oxide, right? So now, which of the hormones uses cyclic GMP as the second messenger? This is atrial natriuretic peptide and brain natriuretic peptide. Just the atrial natriuretic peptide uses cyclic GMP as the second messenger. So a brief look at some important one-liners, some important points as far as the hormones are concerned. Now, which are the hormones? Now, there are two categories of hormones. You have the water-soluble hormones and you've got the lipid-soluble hormones. Now, as far as the lipid-soluble hormones is concerned, the lipid-soluble hormones can cross the cell membrane, right? Because cell membrane is basically lipid. It has a large content of lipids. So the lipid-soluble hormones can cross the cell membrane. So receptors for the lipid-soluble hormones can be either in the cytoplasm or on the nucleus. Two hormones which have got nuclear receptors are thyroid and estrogen. Thyroid and estrogen, extremely important, has been asked as a question. And just to elaborate on this, remember date. Easy for you all to remember, yes? Vitamin D also has a nuclear receptor. Vitamin A also has a nuclear receptor. Thyroid and estrogen. So these have got nuclear receptors. Date. All other lipid-soluble hormones such as progesterone, testosterone, glucocorticoids, aldosterone, they all have cytoplasmic receptors. So extremely important point. Then all the water-soluble hormones, their receptors will be on the membrane surface. Water-soluble hormones cannot cross the cell membrane, so the receptors will be on the cell membrane. Therefore, they need second messengers. Like I told you, cyclic AMP, cyclic GMP, IP3, DAG, right? Now, there are some water-soluble hormones which do not need a second messenger, and that is insulin, IGF-1. Why insulin and IGF-1 do not need second messengers? This is because the receptor itself has tyrosine kinase activity. So it does not need, these two do not need second messengers because the receptor themselves have got a tyrosine kinase activity. Growth hormone, prolactin, leptin, erythropoietin also do not need second messengers because they act via what is known as the JAK-STAT pathway. So again, second messengers are not required. They act via the JAK-STAT pathways. So extremely important again, yes, hormones which do not need second messengers. Hormones which use cyclic GMP as a second messenger, I've already discussed it with you, that is going to be ANP, atrial natriuretic peptide. Now, an extremely important table, and that is which are the second messengers for different hormones. Now, please remember, hypothalamic hormones. Hypothalamic hormones are releasing and inhibiting hormones. So, hypothalamic hormones CRH, GHRH, they use cyclic AMP as the second messenger. But TRH and GnRH use IP3, phospholipase C system. So just be a little careful about this, right? Remember CRH, C for cyclic AMP, also GHRH. And for phospholipase C, TRH, that is thyrotropin releasing hormone and gonadotropin releasing hormone. Cyclic AMP, corticotropin releasing hormone, as well as the growth hormone releasing hormone. Somatostatin is an inhibitory hormone. So it decreases cyclic AMP. Dopamine or prolactin inhibiting factor is also an inhibiting hormone. It reduces cyclic AMP. Right? So remember the two hypothalamic hormones which use phospholipase C is TRH and GnRH. All anterior pituitary hormones will be cyclic AMP except growth hormone. We've already discussed growth hormone does not need a second messenger, right? Because growth hormone acts via the JAK-STAT pathway. Growth hormone as well as prolactin, they do not need second messengers, right? So they do not. But all the other anterior pituitary hormones such as FSH, LH, TSH, they will need cyclic AMP as the second messenger. Posterior pituitary hormones, ADH V2 receptor is cyclic AMP, V1 and V3 receptor is IP3. There are three receptors for antidiuretic hormone from the posterior pituitary, that is V1, V2, V3. Only V2 is the cyclic AMP, V1 and V3 use IP3. Miscellaneous for glucose metabolism, two hormones, insulin, glucagon. Insulin does not need a second messenger because the receptor itself has tyrosine kinase activity. Glucagon uses cyclic AMP. For calcium metabolism, two main hormones, parathormone and calcitonin, both will use cyclic AMP. Catecholamines, you've got alpha receptors and beta receptors. Beta adrenergic receptors, beta 1 and beta 2, they both will use cyclic AMP as a second messenger. What about IP3? Alpha adrenergic response is IP3, angiotensin 2, IP3, gastrin, histamine, especially H1 receptor will be IP3. H2 is cyclic AMP, right? So extremely important table, right? Which are the hormones using cyclic AMP as well as the IP3. Go through this table. There is a little confusion about the hypothalamic hormones, but remember CRH. Some people say CRH uses IP3, but remember C for CRH, C for cyclic AMP, so it uses cyclic AMP. That is the better answer. IP3 is TRH and GnRH. All anterior pituitary hormones except growth hormone and prolactin, which do not need second messengers, will use cyclic AMP. Posterior pituitary V2, for V1 and V3 IP3, and for oxytocin also IP3. And miscellaneous for glucose metabolism, glucagon, for calcium metabolism, parathormone and calcitonin, and beta adrenergic response will be cyclic AMP. On the other hand, this side will be alpha adrenergic response, angiotensin 2, gastrin, and histamine. Now, a patient with a known brain tumor learns that his pituitary stalk has been affected. Secretion of which of the following hormones would likely to be increased after sectioning of the pituitary stalk? Now, all the anterior pituitary hormones, they are under the control of hypothalamic hormones. In the hypothalamus, two important nuclei, paraventricular and arcuate. The paraventricular nucleus synthesizes number 1, CRH, and number 2 is TRH. CRH will increase the secretion of ACTH from the anterior pituitary. TRH will increase the secretion of TSH from the anterior pituitary. CRH is corticotropin releasing hormone. TRH is thyrotropin releasing hormone. Then there is an arcuate nucleus. Arcuate nucleus is GnRH, gonadotropin releasing hormone, which increases the secretion of FSH and LH from the anterior pituitary. There is GHRH, which increases the secretion of growth hormone from the anterior pituitary. Two inhibiting hormones, number 1, somatostatin. Somatostatin will decrease the growth hormone secretion, but as you can see over here, for somatostatin I've put dashed lines. This indicates that for growth hormone secretion, it is GHRH which is more important than somatostatin. Another inhibiting hormone secreted by the arcuate nucleus is prolactin inhibiting factor or dopamine, which reduces prolactin from the anterior pituitary. So these are the hypothalamic hormones and their effects on the anterior pituitary. Now, if the pituitary stalk is affected. So if you remember your anatomy, this is the pituitary stalk here, isn't it? The hypothalamic hormones will enter into what is known as the hypothalamo-hypophyseal portal system. Then they go into the anterior pituitary, where they affect the secretion of the anterior pituitary hormones. So if the stalk is sectioned, if the stalk is sectioned, yes, so that means now the hypothalamic hormones cannot reach the anterior pituitary. So which hormones will show an increase? This is going to be prolactin, right? Growth hormone will decrease, because I told you what is the major hypothalamic hormone controlling growth hormone secretion is your GHRH, not somatostatin. Yes, absolutely right. All of you, I think, have got it right. This is answer to this is A. Now, here is another very interesting question. It says a 42-year-old woman presents with progressive fatigue, weight gain, cold intolerance, constipation for the last 6 months. She also reports menorrhagia and difficulty in concentration. Pulse is low, 56 beats per minute. BP is 110/70. She has dry, coarse skin with periorbital puffiness. Her thyroid gland is diffusely enlarged, firm. Laboratory investigations will show you TSH is elevated. T4 is low. There are anti-thyroid peroxidase enzyme antibodies, which are also called anti-TPO, thyroid peroxidase enzyme antibodies. What is the disease over here? The answer to this question will be Hashimoto's thyroiditis, right? Hashimoto's thyroiditis. Yes, that means of course it's going to be a hypothyroidism, right? Here the synthesis of the thyroid hormones is affected. Yes, so this is going to be Hashimoto's thyroiditis. Now, very simple table here, which I'm going to discuss with you because this is so commonly asked. Now, you're given different kind of clinical scenarios. The first one says that there is TSH is elevated. Yes, TSH is elevated. T4 and T3 are low. So that means this is primary hypothyroidism. And because of loss of this negative feedback effect, there is increase in TSH. Yes, TRH will also be elevated here, right? So this is a primary hypothyroidism, the case which we have just discussed, Hashimoto's thyroiditis. Now let's see what happens if it is a secondary hypothyroidism. Secondary hypothyroidism now means it is going to be at the level of the pituitary. There is some sort of a pituitary disease. That means the hormone secreted by the pituitary, anterior pituitary, is affected. So TSH is low. And of course, T4 and T3 will also be low. But what will happen to TRH here? What will happen to TRH here? There is no problem with TRH. TRH here will be elevated. Hypothalamus is not the problem here. The problem is with the pituitary, right? So because there is low T4, T3, then there will be increase in TRH. But because there is a pituitary disease, TSH is low, right? So TSH is low, T4 is low, T3 is low, and the TRH is elevated. This is a secondary hypothyroidism. Let's look at a tertiary hypothyroidism. That means now primary is thyroid, secondary is pituitary, tertiary is hypothalamus. That means now the problem is with the hypothalamus. So TRH is low. If TRH is low, TSH will be low, T4, T3 will be low. So all T3, T4 and TSH and TRH are going to be low, right? So this is your tertiary hypothyroidism. Let's look at primary hyperthyroidism now. That means the problem is something in the thyroid gland, right? It could be Graves' disease, It could be a toxic multinodular goiter. So now the thyroid gland itself is secreting more hormone. So we find that T4 and T3 are elevated, TSH is low, TRH will also be low because of negative feedback effect of high levels of T4, T3. Let's say if there is a problem in the pituitary, let's say there is a TSH secreting pituitary adenoma. That means there is some sort of a tumor in the pituitary which is causing more and more secretion of TSH. So TSH is high. If TSH is high, T4 and T3 will also be high, but TRH here will be low because hypothalamus is functioning normally. So these are different clinical scenarios. You can get questions on these scenarios and you should be able to answer. Please remember, thyroid, pituitary, hypothalamus. Disease in the thyroid, primary hypothyroidism. It could be primary hyperthyroidism as well. If it is a hypothyroidism, that means the problem is in the thyroid, then TSH and TRH will both be elevated, right? If the problem is in the pituitary, let's say that is called a secondary hypothyroidism. That means TSH secretion is low, so T4, T3 will be low, but TRH will be elevated. If it's a tertiary hypothyroidism, that means problems in the hypothalamus. So TRH is low, TSH is low, T4, T3 is low. Reverse, if it's a primary hyperthyroidism, that means the problem is in the thyroid gland itself. So T4, T3 are elevated, but TSH, TRH will be reduced. If it's a pituitary problem, that means there is a tumor which is being secreted, which is actively secreting TSH. A pituitary adenoma, high levels of TSH means high T4, high T3, but negative feedback effect on the hypothalamus reduces TRH. So you should be able to answer your clinical scenarios based on this table. Let's look at another very interesting question, which has been asked in your FMG exam, and that is, here you can see there is hypothalamus, GnRH from the hypothalamus. It acts on the anterior pituitary, causes secretion of FSH and LH. FSH receptors are on Sertoli cells. S in FSH, S in Sertoli. Sertoli cells will secrete inhibin, and this has a negative feedback effect on the secretion of FSH. LH receptors, L for LH, L for Leydig. Leydig cells, LH receptors are present on Leydig cells. Leydig cells will secrete testosterone. Testosterone has a negative feedback effect on the secretion of LH and GnRH. Right? Testosterone also has an excitatory effect on the Sertoli cells. So the question here being asked is, what is A, what is B? So A is inhibin and B is testosterone. Right? So this is as far as your regulation of the sex hormones are concerned. This is in a male. Right? So this is as far as your now okay. Now, a few one-liners from endocrinology. Zona glomerulosa of the adrenal cortex will secrete aldosterone. Zona fasciculata, which is the largest zone, secrete glucocorticoids. And zona reticularis, mainly androgens. Now, there are two very important terms which have been asked earlier as questions: lactopoiesis and lactokinesis. What is lactopoiesis? Like you have done erythropoiesis, production of RBCs. Lactopoiesis is production of milk by the breast tissue, by the mammary glands. So lactopoiesis and lactokinesis. Kinesis means movement. What is causing movement of the milk? That is lactokinesis. So lactopoiesis is done by prolactin. Prolactin will increase the mRNA. It increases the synthesis of milk proteins. And that is how it increases the milk output. Milk proteins are casein, lactalbumin, right? Casein, lactalbumin. So remember, lactopoiesis is a function of prolactin. But lactokinesis, which is causing a milk letdown effect, that is a function of oxytocin, right? Oxytocin. So this is two important terms, lactokinesis and lactopoiesis. Now, beta cells of the pancreas, you've got alpha cells, beta cells, delta cells, epsilon cells in the pancreas. So beta cells of pancreas will secrete insulin, plus, very importantly, a hormone which is known as amylin. Alpha cells of the pancreas will secrete glucagon. When I look at insulin, what are the target organs for insulin? Target organs for insulin are the adipocytes and the muscle cells. And insulin will increase the GLUT4 in these tissues. GLUT4 is an insulin-dependent GLUT. Remember, target organ for glucagon is not the adipocytes, not the muscle cells, but the liver. Next important point, parathormone receptors. Parathormone is a hormone secreted by the parathyroid glands. Parathormone receptors are present on osteoblasts. Yes, it causes an increase in osteoclastic activity, but the receptors are present on osteoblasts. On the other hand, calcitonin receptors are present on osteoclasts. C in osteoclast, C for calcitonin. Now, the action of parathormone, basically, what causes increase in parathormone secretion? When there is a reduction in the plasma calcium level. So parathormone will now try to bring the calcium level back to normal, so it increases the reabsorption of calcium in the DCT, but it has an effect on the phosphate. It reduces the phosphate reabsorption, so it increases the urinary loss of phosphate. So it reduces the plasma phosphate level, but it increases the plasma calcium level. Parathormone will also increase the osteoclastic activity in the bone, so that there is going to be increase in plasma calcium. But remember, receptors are present on osteoblasts. Calcitonin comes from where? Calcitonin comes from the thyroid gland. So there are parafollicular C cells. What are these are follicles, these are thyroid follicles, right? These are the thyroid cells. Now, parafollicular, that means present here. These are para next to follicles. Parafollicular C cells, which are going to secrete calcitonin. Calcitonin receptors are present on osteoclasts. What is the role of calcitonin? Calcitonin will decrease osteoclastic activity. In normal physiological levels, calcitonin is not important in calcium metabolism. What is more important in calcium metabolism is parathormone and vitamin D. Right? But remember, calcitonin is used in the treatment of Paget's disease. Paget's disease, there is a lot of osteoclastic activity. To reduce the osteoclastic activity, calcitonin is used. What is important for calcium metabolism is parathormone and vitamin D. Vitamin D increases the calcium and phosphate reabsorption from kidney and intestine. Parathormone increases calcium reabsorption from the DCT, but it reduces phosphate absorption. Vitamin D increases both calcium and phosphate reabsorption from not only from the kidney but also from the intestine. All of the following hormones are regulated by positive feedback mechanism except Dr. G5831, thank you very much for your kind words. It is, every time, even after teaching for more than 20 years now, every time I hear a compliment, I feel very happy. So just like anybody else, but thank you very much. All right, so all of the following hormones are regulated by the positive feedback mechanism except. Now, positive feedback mechanism. What is positive feedback mechanism? That means here the initiating stimulus is enhanced, right? See, what is negative feedback mechanism? Negative feedback, like we discussed for, let's say, TRH, we said increases the secretion of TSH from the anterior pituitary, TRH is from the hypothalamus, which in turn increases the secretion of T4 and T3 from the thyroid gland. T4 and T3 have a negative feedback effect on the secretion of TSH as well as TRH. So what is negative feedback? Increase in T4, T3 is reducing TSH and TRH levels. So that means this is the initiating stimulus. This is actually getting reversed, right? If there's a fall in T4, T3, TSH and TRH will increase. Have you understood? So that is negative feedback. What is positive feedback? In positive feedback, estrogen, now LH increases estrogen and estrogen also increases LH. That is called a positive feedback. And this causes what is known as the LH surge, right? So LH is definitely by positive feedback mechanism. Positive feedback of estrogen on LH is responsible for a sharp rise in LH, which is called LH surge, right? Oxytocin. Now, oxytocin is responsible for the milk letdown reflex. Milk letdown reflex is when the mother is feeding the baby. Baby suckles on the mother's breast. This suckling now causes the release of oxytocin from the posterior pituitary, which causes milk letdown reflex. The milk enters into the baby's mouth, causes more suckling, more release of oxytocin, more release of milk. So this is also a positive feedback. Prolactin. Prolactin is responsible for lactopoiesis. Again, suckling by the baby causes more release of prolactin, which increases milk production. More milk in the baby's mouth causes more suckling and more release of prolactin. So this is also positive feedback. But thyroid, as we have just discussed, is by a negative feedback mechanism. Negative feedback mechanism. Excellent. Now, so positive feedback, like I said, LH, oxytocin, and prolactin. Examples of positive feedback, very commonly, positive feedback is a question which has been asked again and again in your exams, and you should be able to answer that. The acronym for that is CLAPS, C, clotting, C, calcium release from the sarcoplasmic reticulum. Calcium release from the sarcoplasmic reticulum during a muscle contraction. This is called calcium-induced calcium release, CICR, which occurs in all muscles, skeletal, cardiac, smooth. I read somewhere somebody has said that it does not happen in skeletal muscles. No, that is incorrect. It happens even in skeletal muscles. It happens in all muscles. Right? Then L is LH surge and milk letdown reflex. A is the upstroke of the action potential. This is a positive feedback mechanism. Then activation of inactive pancreatic enzymes to an active form. That is also positive feedback. Parturition, the process of delivery, and the uncompensated or decompensated shock is also an example of positive feedback. So this is CLAPS. Clotting, calcium release from the sarcoplasmic reticulum during a muscle contraction, LH surge and the milk letdown, deep upstroke or depolarization phase of action potential, as well as activation of inactive pancreatic enzymes to their active form, parturition and shock. Okay. Which insulin-dependent GLUT is present on adipocytes? Now, again, a question which is very commonly asked, and that is going to be GLUT4, isn't it? This is present on adipocytes, on resting skeletal muscles, on cardiac muscles, and to some extent even on the liver. Now, this table becomes extremely important. Yes. Now, there are these 5 different or 7 different types of GLUT. Most importantly, we concentrate on the first 5, right? Now, GLUT1, 1 is supreme. So 2 of the prime cells are, number 1, brain and RBCs. So RBCs and the blood-brain barrier have got GLUT1. Also the placenta and the cornea, but mainly remember one, which are the two most important cells in the body, RBCs and brain. So blood-brain barrier and RBCs have got GLUT1. Now GLUT2 is the beta cell pancreas. It is present in the liver. It is present in the kidney. Liver becomes extremely important. The most important GLUT which is present on the liver is not GLUT4 but GLUT2, right? Beta cell of pancreas, liver, in the kidney, PCT. It is also present in the intestine. And but remember, very important in the liver, in the kidney, and of course the beta cells of pancreas. Okay, GLUT4. Just 1 second, please. Sorry. GLUT4 is the insulin-dependent GLUT. Whenever there is increase in insulin, insulin will increase the sorry, we forgot GLUT3. GLUT3 we said is again brain, but now it is going to be neurons and also in the placenta. GLUT4 is the insulin-dependent GLUT. Insulin will increase the insertion of GLUT4 in the adipocytes, muscle cells, that is both the skeletal as well as the cardiac muscle cells. GLUT5 is a specific fructose transporter. This is found in the jejunum and in the sperms. Now, GLUT6, brain, spleen, WBCs, GLUT7, liver. So please remember once again, GLUT1 to the two most important cells, that is RBCs and the blood-brain barrier. GLUT2, which is going to be present on the beta cells, most importantly on the liver. Liver, the major GLUT is GLUT2, right? It is also present in the PCT. Most of 90% of the glucose absorption in the PCT is done by GLUT2. It is also present in the small intestine, but remember, small intestine as well, it is going to be GLUT2. Present in the brain, neurons will be GLUT3 and also in the placenta. GLUT4 is the insulin-dependent GLUT, GLUT5 is a specific fructose transporter, and GLUT6 and 7, these are brain, spleen, WBCs, GLUT6 and GLUT7 is. But remember, most important GLUT in the liver, which has been asked as your question, is going to be GLUT2. Most important GLUT in the kidney is also going to be GLUT2, right? Intestine, GLUT2. Brain, it means basically neurons, then it is GLUT3. Specific fructose transporter, GLUT5. Insulin-dependent GLUT, GLUT4. Which is a glucose sensor. This is GLUT2, which is present on the beta cell of pancreas. Which GLUT has the highest affinity for glucose? This is going to be GLUT3. GLUT3, which is present on the neurons. This has got the highest affinity for glucose, which makes a lot of sense, right? Because the most important fuel for the brain, for the neurons, is glucose. Yes, so the GLUT3, which is present on the brain, on the neurons, has the highest affinity for glucose. Okay. Which of the following electrolyte imbalances results in increased nerve excitability? Right? Is it going to be hyponatremia, hypokalemia, hypocalcemia, or hypochloremia? So hyponatremia, low sodium levels, low potassium levels, low calcium levels, or low chloride levels. Now, hyponatremia does not affect the membrane neuron excitability. Hypokalemia, if there is a low in the plasma, how much is normal plasma potassium? Normal plasma potassium is 3.5 to 5 millimoles or milliequivalents per liter. Right? So if there is a fall in the plasma potassium level, it causes what is known as a hyperpolarization, which increases the excitability. Right? Which not increases, which decreases the excitability. Hyperpolarization, the RMP of the neurons becomes more negative. right? So it reduces the excitability. Muscle weakness is a very common complication of a patient of hypokalemia. Generally, patients of hypokalemia present with muscle weakness. They'll come to you and say कि हाथों पैरों में जान नहीं है ना? And when you get the electrolytes done, potassium is low. So hypokalemia causes the RMP of the neurons and muscles to become more negative, reducing their excitability. Right? On the other hand, if there is a hyperkalemia has got a dual effect. If it is a mild to moderate increase, it causes a depolarization and an increase in excitability. But if it's a severe or a very large increase, if it's a severe hyperkalemia, it in fact reduces the excitability. Right? So hypokalemia is also, here we are asking what is increased nerve excitability. Hypocalcemia definitely increases the nerve excitability, isn't it? In hypocalcemia, you've heard of carpopedal spasms, Trousseau's sign, isn't it? Schwostek sign positive, increased neuronal and muscle excitability. Hypochloremia also does not affect the nerve and muscle excitability. It is going to be hypocalcemia. Hypocalcemia, you know, these are carpopedal spasm. It's also known as Trousseau's sign, isn't it? Trousseau's sign. In hypocalcemic, it's also known as tetany, hypocalcemic tetany, right? Okay, so please remember, if it's a hypokalemia, it causes a hyperpolarization. Hypokalemia will cause a hyperpolarization and a decreased nerve and muscle excitability. Widened QRS, prolonged QT will be seen in hypokalemia. Mild to moderate hyperkalemia, depolarization, increased excitability, arrhythmias are seen. Severe hyperkalemia, you get tall tented T waves, widened QRS, wide increase in QT interval, because there is a decreased excitability, there is decreased contractility, there are weaker systoles. In hypocalcemia, it results in increased neuronal and muscle excitability, causing tetany. Okay. Again, some important one-liners. Yes, trying to cover up as many questions as possible for you, so that, you know, by going through this 2-hour or 3-hour video, you should be able to cover a huge chunk of your physiology. So I will highly recommend going through this, either a PDF of this or the video itself before the exam, because there's a lot of questions which are being covered here. How much is normal plasma osmolality? Normal plasma osmolality is 280 to 290 milliosmoles per liter, but if I have to choose one value, it is going to be 290. Maximum contribution to plasma osmolality is going to be by sodium. Extremely important to understand that. By sodium. Sodium contributes the maximum to plasma osmolality, almost 270 milliosmoles out of 290. Normal colloid osmotic pressure, which is also known as the oncotic pressure. How much is that? This is 25 to 28 millimeters of mercury. And the protein which contributes to the oncotic pressure is because of proteins in the plasma. You know, there are so many proteins in plasma: albumin, globulin, fibrinogen, prothrombin, all the clotting factors, ceruloplasmin, transferrin. These are all different kinds of proteins which are present. But the maximum contribution to oncotic pressure, or the plasma colloid or oncotic osmotic pressure, is by albumin, because albumin is the most abundant protein. Next important one-liner: blood-brain barrier. This is formed by what? You know that substances cannot move freely from the blood into the brain. There is a barrier which exists. And what is this barrier formed by? It is formed by the tight junctions between the endothelial cells of the cerebral capillaries. Right? Cerebral capillaries. Then there is also something known as a blood-testes barrier. What is this blood-testes barrier? It protects the developing sperms from harmful agents in the blood. Again, substances in the blood, drugs, toxins, etc., cannot move freely into the testes because of the blood testes barrier, which is formed by the tight junctions between the Sertoli cells. Sodium potassium ATPase pump is an example of, this is a primary active transport. Primary active transport. And for sodium potassium ATPase pump, there's a little acronym which I've told you, NOKIA. Isn't it? NOKIA 321. Sodium potassium ATPase pump will pump 3 sodium out of the cell, 2 potassium into the cell for each ATP hydrolyzed. Yes, so NOKIA 321, which is a carrier-mediated transport which does not require energy. See, what does not require energy is passive transport. So all active transports require energy. Passive transports do not require energy. Now, passive transport can be simple diffusion, facilitated diffusion. Facilitated diffusion is carrier-mediated. So a carrier-mediated transport which does not require energy is going to be facilitated diffusion. And examples of facilitated diffusion we've just done. GLUT. GLUT is an example of facilitated diffusion. We've done all the different types of GLUT, isn't it? Glucose transporters. Facilitated diffusion, that is, the transport of glucose is mediated by proteins, by carrier proteins. But facilitated diffusion does not require energy. It requires a protein, but does not require energy. All right. Let's see another important topic, and that is CNS examination is being performed in a patient with a stroke with the patient's eyes closed. The big toe is moved up and down while holding the proximal metatarsophalangeal joint. The proximal metatarsophalangeal joint. In this case, I'm showing you on the hand, but this is being done on the foot. So here the metacarpophalangeal joint is being held and the digit is moved up and down. Patient's eyes are closed and patient has to identify what is the position of his toe. In this case, like I said, we are doing it in the lower limb. Which is basically this is what is proprioception or proprioception. What is proprioception or proprioception? This is nothing but joint and position sense. Joint and position sense, right? Now this is carried by the fastest, largest diameter, fastest conducting nerve fiber, and that is A alpha. So this is going to be A alpha. A alpha is responsible for joint and position sense, for proprioception. This is the largest diameter and fastest conducting. Now, let's go through the nerve fiber classification. This is so important because lots of questions are asked. Now, when I look at A alpha can be your somatic motor, or it can be for proprioception, joint and position sense. Yes. Now, this is what is known as the Erlanger and Gasser classification. Type A, type B, type C, this comes under Erlanger and Gasser classification, which is meant for all types of neurons, whether they are sensory, motor, autonomic. There is another type of classification which is known as the numerical classification, that is called the Lloyd and Hunt's. Numerical classification. Right? Lloyd and Hunt's numerical classification is only meant for sensory neurons. It is not meant for motor or autonomic. That means a motor neuron will not have any number. It does not exist in the numerical classification. Right? No, numbers are only given to sensory. So the type A for proprioception is known as type 1. And type 1 is further subdivided into 1A and 1B. 1A is the sensory fiber from the muscle spindle and 1B is the sensory fiber from the Golgi tendon organ. Muscle spindle and Golgi tendon organs are two very important receptors for proprioception. Right? So 1A is from muscle spindle and 1B is from Golgi tendon organ. A beta. A beta is meant for fine touch. This is meant for vibration. This is meant for proprioception. It is meant for deep pressure. And it is also meant for proprioception. This is known as the type 2 fiber, but proprioception only from the muscle spindle. In other words, the sensory fiber from the muscle spindle are 1A and 2. Sensory fiber from the Golgi tendon organ is only 1B. A gamma. A gamma is a motor neuron. This is motor to the muscle spindle. It is motor to the intrafusal muscle fibers in the muscle spindle. So obviously no number in the numerical classification. Numerical classification is only numbers only meant for sensory. A delta. A delta is meant for fast pain. Absolutely right. It's Dr. Ankit. Fast pain. It is also meant for temperature. But in temperature, it is meant for cold sensation. And it is also responsible for some mechanoreception. That means some forms of touch. This is your type 3 fiber. Type B. Type B is your preganglionic. Type B is your preganglionic autonomic, no number again. Type C. Type C is your postganglionic autonomic. Again, no number. But type C, which is the slowest conducting, smallest diameter, slowest conducting, this is meant for crude touch. It is meant for pressure. It is meant for slow pain. It is meant for temperature. In temperature, it is meant for cold and warm. So this is my type 4 fiber, right? Type 4. So type 4 or type C, these are maximum in number as well, right? They're most numerous are your type C or type 4, and they're meant for crude touch, for pressure, for slow pain, and for temperature, which is cold and warm. So if you look at this, the fibers for cold are both A delta and C. For warm, it is only C. For deep pressure, the fiber is A beta. But if the question says only pressure, my answer is C. Fiber for fast pain, A delta. Fiber for slow pain, C. Fiber for vibration, A beta. Fibers from muscle spindle, 1A and 2. Fibers from Golgi tendon organ, only 1B. So it's simple, straightforward questions can be asked from this particular table. Let's have a look at, in the adjoining graph of the action potential, at what point is the sodium potassium conduction the least? So the graph, is missing. So let me just make it for you. So this is minus 70 millivolts, the resting membrane potential. This is an action potential which has been given. And the points are point A, point B, point C, point D, and point E. No, sorry. I'll just make this once again. Okay. A is resting membrane potential. B is middle of depolarization. C is here. D was here and E was here, right? So now the question says, at what point is the sodium conduction the least? Sodium potassium conduction. That means if I'm looking at the ratio, when do I get a least ratio is when the sodium conduction is the least and potassium conduction is the maximum. Isn't it? Potassium conductance is the maximum. So when I look at this, now please remember, the upstroke is due to opening of fast voltage gated sodium channels, right? They're fast channels, fast to open, fast to close. So the moment I give a stimulus, yes, it causes these fast voltage gated sodium channels to open. So if I look at the sodium conductance, what is sodium conductance? Sodium conductance means how many sodium ions are passing through the membrane at a given point of time. So if I look at the sodium conductance, at rest the sodium conductance is 0. The moment we give a stimulus, the conductance, now sodium channels will open and sodium starts moving from outside to inside. So there is a sharp rise in the sodium conductance. And because of this sharp rise in the sodium conductance, there is going to be the upstroke of the action potential. And because these are fast sodium channels, the sodium channels very rapidly close. So this is your sodium conductance, or the permeability of the cell membrane to sodium. Right? At rest 0, give a stimulus, fast voltage gated sodium channels will open, sharp increase in conductance. And that is why the potential changes from, because the cell is gaining positive charge, potential of the cell is changing from minus 70, then it goes to the firing level of minus 55, after which the opening of sodium channels is by a positive feedback mechanism. So sudden influx of sodium. And the potential goes up to 0 and crosses 0 and goes up to plus 30. So as a result of this increase in sodium conductance, there is a change in potential from negative towards a positive value, right? Now what about potassium? Potassium conductance. Potassium conductance at rest is more than sodium, because at rest the cell membrane is permeable to sodium, almost freely permeable to sodium, right? Now when we give a stimulus, potassium channels are slow channels, so they're slow to open, and because they're slow to open, they begin to open once the sodium channels have already begun to close. And then you have so if this is the potassium conductance here, yes, there is a slow rise in the potassium conductance. Why slow rise? Because I told you potassium channels are slow to open and they are even slower to close. So this is your potassium conductance. Now at what point is the sodium potassium conductance the least? How do you get sodium potassium conductance? How is the ratio going to be least? When sodium conduction is less and potassium is more. So let's see at point A. At point A, sodium conductance is almost 0. I will not call it exactly 0, almost 0, but the potassium conductance is very high. Is higher, not very high, but higher than sodium. At point B, it's the sodium conductance which is high, so it cannot be point B. At point C, sodium conductance is very high, so it cannot be. But look at point D. At point D, we find that sodium conductance is less, but the potassium conductance is much more, right? Sodium conductance is less, is decreasing, but the potassium conductance is definitely more. And at point E, sodium conductance is almost 0, potassium conductance has reduced, right? So here the point where we will get, let me see, what is your answer? So point E, now point E, what has happened is sodium conductance is almost 0 and potassium has reduced. Yes, potassium has reduced. Have you understood? Right? Though it is still higher than the potassium conductance at point A. Yes? But what about point E? At point E, the sodium conductance is reducing, though it is not really touching the baseline at this point. And potassium conductance is much more than normal, right? So, at what point will the sodium potassium conductance this will be my point. E. Right? Better than point A will be point E. Right? Better than point A will be. Salam, why not point C? Because at point C, sodium conductance is very high. We want the ratio to be the least. Have you understood? Ratio will be least when numerator is very low and denominator is higher. Right? So, at point E, sodium conductance is almost zero, but potassium conductance is still higher than at point A. So, better answer than point A is point E. C नहीं हो सकता है. Salam? Have you understood? C क्यों नहीं होगा? क्योंकि C पे सोडियम कंडक्टेंस ज्यादा है, तो रेशियो बढ़ जाएगा. ठीक है? D भी नहीं हो सकता क्योंकि D पे सोडियम कंडक्टेंस बेसलाइन से ज्यादा है और पोटेशियम कंडक्टेंस मैक्सिमम से कम है. तो अभी दोनों की कंडक्टेंस हाई है. हमें लीस्ट चाहिए. लीस्ट होगी या तो ए पे या पॉइंट सी पर. इज इट ओके? ठीक है, ये आप ही के एग्जाम का क्वेश्चन है. दैट इज व्हाई आई हैव स्पेंट अ लिटिल टाइम डूइंग दिस फॉर यू. ठीक है? ऑलराइट. अगर ई नहीं होता देन माय आंसर वुड हैव बीन ए. ठीक है? Alright, one-liners. RMP of most neurons, minus 70 millivolts. RMP is mainly due to potassium. Most diffusible ion at rest, potassium. Depolarization phase of the action potential is due to influx of sodium through fast voltage gated sodium channels. Repolarization is due to closure of sodium and efflux of potassium. Through which channels? Slow voltage gated potassium channels. Large diameter myelinated nerve fibers are the fastest conducting. Which is the largest diameter? A alpha. A beta is less, A gamma is lesser than that, A delta, then B and C. As you go from A to C, the diameter reduces, velocity of conduction reduces. Fastest conducting nerve fiber will be A alpha, slowest conducting will be type C. Okay. All right. Now, I'll take a small 10-minute break, right? This is an intensive session. So I just want a little break for 10 minutes and then we can resume. Yes? Let's just take a break for 10 minutes. दस मिनट का ब्रेक है. बस थोड़ा सा ब्रेक चाहिए. नहीं हुआ? Hello. कहाँ से ऑन करना है? Okay. All right. So welcome back. Welcome back, and we will continue our session. Some more important topics to be discussed. So let's see them. All right. Now the next one is on periodic breathing. Now these are special type of breathing which occurs in certain situations, and let's have a discussion. A 40-year-old man is brought to the emergency department after sustaining a head injury in a fall. He's unconscious, unresponsive, his blood pressure is elevated, respiratory pattern is as shown below. What is this? There are periods of gradually increasing depth and rate of breathing, followed by a gradual decrease and a brief apnea. There is an increase in the rate and depth, and there is a decrease. These are called spindles. This is what is known as the Cheyne-Stokes breathing, which is very common in head injuries and in cardiac failure. Now, what is Kussmaul's? Kussmaul's, there is an increase in, Kussmaul's is like this. There is an increase in the rate as well as the depth of ventilation. Kussmaul's breathing, right? There is an increase in the rate and depth of ventilation. So these, in all causes of metabolic acidosis, anything which causes metabolic acidosis will cause Kussmaul's breathing, right? Metabolic acidosis, the two important D's for metabolic acidosis are diarrhea and diabetic ketoacidosis. Diabetic ketoacidosis, DKA. These are two important causes of metabolic acidosis where you'll see Kussmaul's breathing. What is Bayert's breathing? In Bayert's breathing, there is an increase in the rate and depth of ventilation, then apnea. There is an increase in the rate of not the depth, but increase in the rate of ventilation, that is called hyperapnea, followed by apnea. Hyperapnea followed by apnea. This is a very serious form. This indicates a very serious underlying condition. It indicates neuronal damage, right? That is what is known as Bayert's breathing. Yes? Then what is apneustic breathing? In apneustic breathing, this is seen whenever there is what is apneustic breathing? Whenever there is a mid-pontine section of the mid-pontine section. You know that there is a mid-pontine section. It could be due to trauma, it could be due to a vascular injury, it could be due to a tumor. What is mid-pontine section? Mid-pontine means, there is you have the pons, the medulla, and then you have the spinal cord, isn't it? And above the pons is the midbrain, and then you have the cerebrum, isn't it? So a mid-pontine section this way, that means middle of the pons, there is some sort of a section, either traumatic section or due to a vascular injury or due to a tumor. This gives rise to what is known as the apneustic breathing. And what is apneustic breathing? Apneustic breathing, there are prolonged inspiratory spasms. It's like this. He takes an inspiration and remains in inspiration for a long time. So this is called prolonged inspiratory spasms. Right. So this is what is known as your apneustic breathing. So we've done the Cheyne-Stokes breathing, the Bayert's breathing, Kussmaul's, as well as apneustic breathing. Okay. Let's go on to the next one. Now this is also an important question. Two friends with a history of having dined at a restaurant present with progressive difficulty in swallowing and speaking. They both have flaccid muscle weakness and hypotonia. Deep tendon reflexes are reduced. Sensory examination is normal. One has consumed home canned food. Home canned food, so obviously it is not, it is not the best preserved. So home canned food, what is common is botulinism. It gets contaminated by Clostridium botulinum. Botulinism is common with home canned food. And the other has consumed unprocessed puffer fish. Unprocessed puffer fish has got what is known as tetrodotoxin. Now, botulinum toxin and tetrodotoxin, what is the effect? Botulinum toxin will act on the neuromuscular junction. Now, firstly, neuromuscular junction. Neuromuscular junction is between the A alpha motor neuron and the muscle fiber. Right? And what is the neurotransmitter which is secreted at the neuromuscular junction? That is acetylcholine. The A alpha motor neuron has got these vesicles which contain acetylcholine. And acetylcholine is exocytosed here at the neuromuscular junction. Now, botulinum toxin will act on what are known as docking proteins. It inactivates what are known as docking proteins. Docking proteins are also known as snare proteins. So it will act on these docking proteins and it will inactivate them. So there is going to be no exocytosis of acetylcholine, and the type of paralysis you see in botulinism is a flaccid paralysis. So this is the reason for the flaccid paralysis in botulinism. In pufferfish, tetrodotoxin, what is the effect of tetrodotoxin? Tetrodotoxin, it acts on the sodium channels. It acts on the sodium channels and it causes their closure. It does not allow them to open. So there is no generation of an action potential here. That is the mechanism of action of tetrodotoxin. Tetrodotoxin specifically acts on the sodium channels. So answer to this question is actually A. The other options you can read once you're revising this. Canned food is contaminated with botulinum toxin, which inhibits the release of acetylcholine at NMJ by inhibiting the docking proteins or the snare proteins. And unprocessed puffer fish has got tetrodotoxin that will inhibit the sodium entry by blocking the sodium voltage-gated sodium channels. So answer is A. Right? The effect of botulinum toxin as well as tetrodotoxin. So in the same question, effect of two toxins has been asked. A cross-sectional view of the skeletal muscle fiber through the H zone. Through the H zone will reveal what? So there is an A band or the dark band. If you look at over here, this is the dark band. This is the A band or the dark band, which consists of myosin plus overlapped actin. Then you have a light band, which is called the I band, which is only actin. And remember, half of I band lies in one sarcomere, half lies in a neighboring sarcomere. Within the A band, you have a slightly lighter area, which is called the H zone. What is H zone? H zone is only myosin, right? What is A band? A band is, what is A band? It is going to be myosin plus the overlapped actin. This is your A band or the dark band. Light band is only actin. And half of light band lies in one sarcomere, half lies in a neighboring sarcomere. And within the A band, you have a slightly lighter area, which is called the H zone, and H zone has only myosin. So the question is very specific. It says if you take a cross section at the level of the H zone, what will you see? You will see only myosin, and you all have got it right. Okay, let's go on to the next one. A child is brought by his mother with complaints of weakness, difficulty in walking and climbing stairs from childhood. She also states that he's unable to do day-to-day activities. His calves are bilaterally hypertrophied. Gover's sign is positive. What is Gover's sign? You ask him to get up, he takes the help of his own body to get up. He gets up like an old man, right? So which workup shows no functional dystrophin? Dystrophin is deficient. This is going to be Duchenne's muscular dystrophy, right? Dystrophin in Duchenne's D, dystrophin is D. Dystrophin also starts with D, is deficient, which also starts with D. So dystrophin is deficient. In Becker's muscular dystrophy, dystrophin is present but reduced. So there is a reduction in functional dystrophin. So remember, Becker's is better. Becker's is better. It is less severe. But even in Becker's, you will be able to see the Gover's sign. Gover's sign positive can be there even in Becker's muscular dystrophy, right? So this is Duchenne's and Becker's muscular dystrophy. As you know that there are these sarcolemmal proteins, right? Sarcolemmal proteins, also known as the dystroglycan. These are your sarcolemmal proteins, which is your dystroglycan, sarcoglycan complex, dystroglycan, sarcoglycan complex, right? And which are these sarcolemmal proteins? Number one is dystroglycan, or number one is dystrophin. Dystrophin links the actin with the beta dystroglycan, right? Then number two, you have syntropin, sarcospan, you have dystroglycan, alpha and beta dystroglycan, and you have the sarcoglycan, which is alpha, beta, gamma, delta. So these are your sarcolemmal proteins. Mutation of these sarcolemmal proteins can give rise to different degrees of dystrophy, muscle weakness, right? There are 20 different types of dystrophies known. We have just discussed two of them. That was Duchenne's, dystrophin is deficient. Becker's, dystrophin is present but reduced. A third one is when there is a mutation of the sarcoglycan complex, that is called the limb-girdle dystrophies. Limb-girdle dystrophy. 5 sarcolemmal proteins: dystrophin, syntropin, sarcospan, dystroglycan, sarcoglycan. A patient presents with unilateral drooping of eyelid, muscle weakness, headache. Symptoms worsen during the evening. Patient feels better after taking neostigmine. What does neostigmine? Physostigmine and neostigmine are anticholinesterases. That means, what are anticholinesterases? Cholinesterase is an enzyme which causes degradation of acetylcholine. So an enzyme which causes degradation of acetylcholine. A drug which inhibits this enzyme will cause a local increase in acetyl. It will cause a local increase in acetylcholine. There is a local increase in acetylcholine, right? So this is used in the treatment of myasthenia gravis. Myasthenia gravis. Please remember, Lambert-Eaton syndrome, also the patient will present with muscle weakness, but in Lambert-Eaton syndrome, the weakness is maximum in the early mornings. Then his weakness improves as the day progresses. Whereas in myasthenia gravis, he feels fine in the morning. Morning is mast, मतलब morning उसका अच्छा है, अच्छा खासा है. दिन सुबह तो बिल्कुल ठीक है, लेकिन शाम तक पहुंचते पहुंचते उसकी fatigue, उसकी थकान बढ़ जाती है, right? Whereas in Lambert-Eaton syndrome, his maximum weakness is in the morning, and शाम तक पहुंचते पहुंचते he becomes better, right? So this is myasthenia gravis. Okay. All right, so this is just the neuromuscular junction, which I've shown you over here, and how is transmission across neuromuscular junction? How does that take place? Yes, remember Lambert-Eaton syndrome is a disease of the presynaptic membrane, and myasthenia gravis is a disease of the postsynaptic membrane. In Lambert-Eaton syndrome, antibodies are against the voltage-gated calcium channels. In myasthenia gravis, antibodies are against the acetylcholine receptors. In Lambert-Eaton syndrome, maximum weakness will be in the early morning. His weakness improves as the day progresses because of accumulation of calcium and more neurotransmitter release. In myasthenia gravis, he's okay in the morning, but towards the end of the day, his weakness is very severe. That is because during the day, repeated stimulation has caused depletion of acetylcholine. A patient of myasthenia gravis feels better after a period of rest or after taking physostigmine, neostigmine. Okay. Yes, lazy morning, Lambert-Eaton. All right. Okay, so the point is, yes, there is always a little bit of confusion, but it's important to clear all your confusion, all your doubts at this stage so that you do not make a mistake during the exam. So confusion now is clarity later, right? So do not get disheartened if you felt that you were not able to answer some of the questions. Doesn't matter. The point is, this session is to improve your clarity, to remove the confusion and take you towards clarity. Okay. A 32-year-old man is brought to the emergency department after a stab wound to the right side of his back at the level of T10. On neurological examination, the following findings were noticed. There is loss of motor power in the right lower limb, loss of vibration proprioception on the right side below the level of lesion, loss of pain and temperature sensation on the left side, right? Vibration and proprioception lost on the same side, pain temperature on the opposite side. So this is very, very typically seen in hemisection of the right side of the spinal cord at T10, right? Right side of the spine. This is the Brown-Séquard syndrome, absolutely right. If it was a complete transection of the spinal cord at T10, then you wouldn't have seen, it would have been complete loss of motor power, complete loss of all sensations. So this is not the answer. If it was only the posterior columns which are affected, then only fine touch, vibration, proprioception would have been affected. Pain temperature would have been intact. If it was only a damage to the anterior horn cells at T10, anterior horn cells are motor, right? So only motor loss would have been there, and that also at T10, right? Below that, there would have been no problem. Okay. So what is hemisection of the spinal cord? If this is the spinal cord, half of it is cut, right? That means the posterior columns which ascend on the same side are cut. Posterior columns carry fine touch, localization, 2-point discrimination, vibration, conscious proprioception, stereognosis. Those are cut. Motor fibers descending downwards have been cut. So motor paralysis on the same side. Loss of vibration proprioception, same side. Now pain temperature fibers cross and then ascend upwards, right? So pain and temperature will be lost on the opposite side below the level of lesion. So how do we remember this? That is going to be bus stop. In Brown-Séquard, there will be loss of pain and temperature on opposite side below the level of lesion. Posterior column sensations are lost on the same side. Motor paralysis will be same side, ipsilateral motor paralysis, right? So these are your important features of the Brown-Séquard syndrome. A 64-year-old man with a history of hypertension and atrial fibrillation is brought to the emergency department with sudden onset weakness of the right side of the body and difficulty in speaking. On neurological examination, he has right-sided spastic paralysis of face, arm and leg. Hyperreflexia, extensor plantar response on the right side, deviation of the tongue to the right on protrusion, impaired speech with preserved comprehension. Impaired speech with preserved comprehension, right? CT scan of the brain shows an ischemic infarct involving the internal capsule. Damage to which of the following tracts is primarily responsible for the patient's motor deficit? Now, there is a right-sided hemiplegia. As you can make out over here, this is a right-sided hemiplegia. Hemiplegia, now because the lesion is at the level of the internal capsule, so this is a UMN paralysis. And which is the tract which is going to be affected? The major tract which is affected here is the corticospinal tract. This is the motor tract. The most important tract for fine skilled movement is corticospinal. This has been affected, right? So I can just discuss this tract with you. Fibers of the corticospinal tract will arise from different parts of the brain. They arise from area 4, area 6. 60% of fibers arise from area 4 and area 6. 40% of the fibers also arise from area 3, 1 and 2. And all these fibers will pass through the internal capsule, right? Internal capsule. They occupy the anterior 2/3 of the posterior limb, and the genu. Anterior 2/3 of the posterior limb and the genu, right? So these fibers which arise from different parts of the brain, area 4, area 6, 60% of the fibers, and 40% from areas 3, 1 and 2, and they pass through the internal capsule, anterior 2/3 of the posterior limb and the genu. Then these fibers descend downwards. They descend downwards. They reach the medulla. 80% of the fibers will cross over to the opposite side, right? This is called the motor decussation. Motor decussation. This occurs in the medulla. This results in the formation of pyramids. This results in the formation of pyramids, right? And this gives rise to a tract which is called the lateral corticospinal tract. Lateral corticospinal tract, which is also known as the pyramidal tract. This is the main tract for fine skilled movements. This is the tract which supplies the A-alpha motor neurons to the distal muscles. So this is the tract which is responsible for fine skilled movements. 20% of the fibers do not cross. And these 20% of the fibers which do not cross will form the anterior corticospinal tract. Anterior corticospinal tract. And anterior corticospinal tract will supply the axial muscles. Axial muscles. So this is meant for posture, tone and posture. Please remember, the major tract for fine skilled movement is your lateral corticospinal tract, also known as the pyramidal tract. This is the main tract for fine skilled movement. This, remember, is a crossed tract. It is formed by fibers which have crossed over to the opposite side. 20% of the fibers which do not cross form the anterior corticospinal tract, and that is therefore an uncrossed tract. Uncrossed tract, right? Uncrossed tract. So this is going to be as far as your motor pathways is concerned, right? Motor pathways is concerned. All right. Let's have a look at the next question. Now this says, A 25-year-old patient after head trauma presented to the emergency room. On neurological examination, he was found to have normal handwriting and could copy shapes of objects but could not speak. Right? The CNS lesion in this patient is most likely to be which of the following? Now, which area of the brain is controlling the motor aspect of speech? That is going to be the Broca's area. Right? He is not able to speak. Right? A lesion of the Broca's area will produce what is known as a non-fluent aphasia. Right? It will produce a non-fluent aphasia, also known as an expressive aphasia, also known as a motor aphasia. Right? Comprehension is a function of the Wernicke's area, isn't it? Now, where is the Broca's area located? This is located in front of the inferior end of, this is the Broca's area, which is the lower end of the frontal gyrus. And where is the Wernicke's area? Wernicke's area is located in the posterior end of the superior temporal gyrus, right? And the two are connected with the arcuate fasciculus, right? Arcuate fasciculus. Angular gyrus is involved in whatever is the visual information which is received. It is involved in understanding that, right? So Broca's, like I said, if there's a lesion of the Broca's area, motor aspect of speech is going to be affected. The lesion is a non-fluent expressive or a motor aphasia. If the Wernicke's area is affected, then the comprehension of both the spoken and the written word is going to go, right? And the lesion is going to be a fluent. He's able to speak, but that speech is making no sense. It's called a fluent aphasia, but it is also called a nonsensical speech. Now, some important points about the different types of aphasia. What does it do to fluency, comprehension, repetition, and where is the lesion located? We've just discussed Broca's, which is expressive or the non-fluent. It's a non-fluent aphasia, not able to speak at all, so he's not able to express himself, but his comprehension is relatively preserved. What about repetition? You ask him to repeat a certain word, he will not be able to do it because obviously his Broca's area is damaged. So lesion here is the inferior end of the frontal gyrus. Wernicke's aphasia. Wernicke's aphasia, that means his comprehension is affected. Yes, so fluency is present, he's able to speak, it's a nonsensical speech, but comprehension is poor. But he obviously, because his comprehension is poor, he will not be able to repeat. The lesion is the superior temporal gyrus. Conduction aphasia. Fluency, it's a fluent if he's able to speak, his comprehension is preserved, but what is lost in conduction aphasia is repetition. You ask him to repeat a word, he will not be able to do it. The lesion, therefore, will be in the arcuate fasciculus. Anomic aphasia. Fluency is, he's able to speak, he's able to comprehend, he's able to repeat, but he's unable to identify, name objects. If you put this in front of him, he'll be able to say, you use this for texting or for speaking to someone, but he's not able to call it a cell phone. Anomic aphasia. Here the lesion will be the angular gyrus, which is in the temporal or the parietal lobe. So this is as far as your different types of aphasia is concerned. Let's look at the next one. Now, a 58-year-old man presents with progressive unsteadiness while walking in frequent falls over the past 4 months. He reports difficulty in performing fine motor tasks such as buttoning his shirt, speech is low, slurred, intention tremor. What is intention tremor? As his hand approaches the objects, the tremor worsens. That is called intention tremor. This is typically seen in cerebellar disease. Yes? In his right hand, finger nose testing reveals past pointing on the right side. Muscle strength, sensory examination are normal. Which are the cerebellar structures most likely to be affected? Right? Now, here you have, firstly, please remember, in Cerebral cortical lesions, cerebral, they affect the opposite side of the body. Like we just discussed, a lesion of the internal capsule affecting the opposite side of the body. But a cerebellar lesion, it affects the same side, right? Here the symptoms are on the right side. So this is going to be a right cerebellar lesion. Cerebellar lesions affect the same side. Cerebral cortical lesions will affect the opposite side, right? So this is going to be right. No, it's not going to be left. Salam. Please remember, cerebellar lesions will affect the same side. Here the problem's on the right side, so the lesion will be on the right cerebellar hemisphere. Are you okay with that? Salam? Okay. All right. A 72-year-old woman with a history of poorly controlled hypertension and type 2 diabetes mellitus is brought to the emergency with sudden onset violent flinging movements of the left arm and leg. So one half of the body is affected. There are sudden violent flinging movements, which is typically known as hemibalismus. Hemibalismus, right? The movements are irregular, proximal, worsen with voluntary action, but disappear during sleep. Neurological examination is otherwise remarkable. There is a small hemorrhagic lesion. Which part of the basal ganglia will be affected? This is going to be subthalamic nucleus. Subthalamic nucleus, right? Subthalamic nucleus will produce what is known as hemibalismus. So just to complete this table, a lesion of the caudate nucleus causes, C for caudate, it causes chorea. What is chorea? Chorea is flicking movements, dance-like. Globus pallidus, a lesion of the globus pallidus causes athetosis. What is athetosis? These are slow writhing movements. A lesion of substantia nigra pars compacta, it causes Parkinson's. A lesion of the subthalamic nucleus causes what we've just discussed, hemibalismus. Now, which are the neurotransmitters secreted? Caudate nucleus and putamen are together known as the striatum. 95% of the striatal neurons will secrete GABA. 5% of the striatal neurons will secrete acetylcholine and somatostatin. 95% is GABA and 5% is acetylcholine and somatostatin. Globus pallidus external segment secretes GABA. Globus pallidus internal segment will also secrete GABA. Substantia nigra pars compacta secrete dopamine. Pars reticularis secretes GABA. Subthalamic nucleus of Lewis is the only one which secretes glutamate. Glutamate, right? So this is as far as your neurotransmitters secreted by different parts of the basal ganglia. And what are the lesions which are going to be seen? Lesions are very commonly asked. C for caudate nucleus, chorea. Globus pallidus, athetosis. Substantia nigra pars compacta, loss of dopaminergic neurons, Parkinson's. And subthalamic nucleus of Lewis will be hemibalismus. Okay. A 45-year-old man is admitted with severe dehydration due to profuse vomiting and diarrhea for 3 days. He is hypotensive and tachycardic. He passes a concentrated urine with low sodium content. Which of the following renal changes is most important in maintaining the GFR in this patient? Remember, there is hypovolemia here. There is hypovolemia, right? Decrease in renal blood flow, decrease in blood volume, decrease in renal blood flow. So there is going to be a decrease in GFR. What is going to help in maintaining GFR? Now, if I constrict the afferent arteriole, remember afferent arteriole will form the glomerular capillaries, right? And then you have an efferent arteriole. Yes? And this is the glomerulus here. So if I constrict the afferent arteriole, I'm reducing the blood flow into the glomerular capillaries. So I will decrease the GFR here. So this is not the answer. If I constrict the efferent arteriole, now there is going to be a back pressure. This increases the hydrostatic pressure in the glomerular capillaries, which will increase the GFR. Increasing glomerular capillary oncotic pressure. Glomerular capillary oncotic pressure does not favor filtration, it opposes filtration. So this will decrease the GFR. Decreased glomerular capillary hydrostatic pressure will also decrease the GFR. So my answer here is constriction of the efferent arteriole. Yes, all of you, Ravi Raj, you've got it right. Himalayan, you've got it right. Yes, so the answer is B, constriction of the efferent arteriole. Now, we know the glomerular filtration membrane. There are, number one, you've got the glomerular capillary endothelium, which is a fenestrated endothelium. Then you have the basement membrane, and then the parietal layer of the Bowman's capsule, the visceral layer of the Bowman's capsule is modified to form podocytes, isn't it? The limiting factor is the limiting factor for filtration is the basement membrane. Basement membrane's permeability is equivalent to a pore size of 8 nanometers. So any neutral particle more than 8 nanometers is not filtered, right? Any neutral particle more than 8 nanometers is not filtered, right? So limiting factor is going to be, like I said, the basement membrane. A neutral particle more than 8 nanometers will not be filtered. So what are the pressures which are responsible for filtration? So if this is the Bowman's capsule, afferent arteriole, glomerular capillaries, efferent arteriole, yes? So the first important pressure which is responsible for filtration is what is known as PGC, hydrostatic pressure of the glomerular capillaries. This is the most important pressure. It is the largest pressure. This is PGC. If I increase the flow into the capillaries, I will increase the PGC and increase the GFR. A force which is opposing this is called the colloid osmotic pressure of the glomerular capillaries, pi GC. There is also a hydrostatic pressure of the Bowman's capsule. This is also opposing GFR. Then the fluid in the Bowman's capsule has a pull force which is called pi BC, colloid osmotic pressure of the Bowman's capsules. These are the 4 important pressures which are involved in filtration. Which are the forces which are favoring filtration? Favoring filtration are 2 forces. There is a PGC and a pi BC. These are the 2 forces which are favoring filtration. And which are the 2 forces which are opposing filtration? Opposing filtration are pi GC and PBC. So forces which are favoring filtration will be positive. So what is my net filtration pressure? This is PGC minus pi GC minus PBC plus pi BC. Why is PGC if PGC is positive, pi BC is also going to be positive, right? Because there are 2 forces which are favoring filtration. Pi GC and PBC are opposing filtration, so they are going to be negative. So my net filtration pressure is PGC minus pi GC minus PBC plus pi BC, right? GFR will be directly proportional to the net pressure. More the net pressure, more the GFR, right? So if there's increase in PGC, more will be the GFR. If there is an increase in pi GC, less will be the GFR. If there is an increase in PBC, less will be the GFR, because these are forces which are opposing filtration. So GFR, if I want to remove the proportionality sign, bring an equal to sign, I have to multiply it by a constant, and that constant is Kf. Kf into PGC minus pi GC minus PBC plus pi BC. What is Kf? Kf is your ultrafiltration constant, and Kf is a product of permeability and the surface area. So factors affecting GFR are: number 1, permeability, surface area, PGC, pi GC, PBC, and pi BC. Right? So this is your pressures responsible for filtration. Now I'm going to discuss this important table here. Again, it will take care of a lot of questions which are asked from GFR. What will happen if I do an afferent arteriolar dilatation constriction, efferent arteriolar dilatation constriction on the renal plasma flow and on GFR? So if I do an afferent arteriolar dilatation, if the afferent arteriole is dilated, remember, afferent arteriole is dilated, that means more flow into the glomerular capillaries. More flow into the glomerular capillaries means what will happen to PGC? Increases. Yes, GFR increases. So there is an increase in the renal plasma flow, there is also an increase in GFR. Right? If I do an afferent arteriolar constriction, there is a plastic pipe, water is going through it, if you put your foot on the plastic pipe, you're reducing the flow. If you reduce the flow, you are also reducing the PGC and the GFR. Fair enough? Now let's see if I do an efferent arteriolar constriction. If the efferent arteriole is constricted, a back pressure is created. There is an increase in PGC and an increase in GFR. But what about the total renal plasma flow? Remember, each kidney has got 1 million nephrons. All the efferent arterioles of these 1 million nephrons are constricted. So what will happen to the total blood flow? Reduces. There is an increase in GFR, but there is a decrease in the renal plasma flow. Sorry, this is for an efferent arteriolar constriction. If I do an efferent arteriolar dilatation, it's going to be the reverse. There is an increase in the renal plasma flow and a decrease in GFR. Right? I'll just write this once again. If I do an efferent arteriolar dilatation, I'm increasing the flow, but I'm decreasing the GFR. But if I do an efferent arteriolar constriction, so I will create that back pressure, I will increase the PGC, increase the GFR, but I will reduce the total flow. Right? So this is what will happen if I do an afferent arteriolar dilatation and an afferent arteriolar constriction. All right. A 27-year-old woman is evaluated for excessive thirst. A 27-year-old woman is evaluated for excessive thirst and passage of large volumes of dilute urine for the past few weeks. Laboratory investigation: serum sodium is 150, plasma osmolality is high, urine osmolality is 90. It's a hypotonic urine. A water deprivation test fails to increase the urinary osmolality but by administration of desmopressin. What is desmopressin? It is a synthetic ADH. Urine osmolality increases to 600. Right? In which segment? So that means basically you must understand what is the role of ADH? ADH will increase the water reabsorption and produce a concentrated urine. Here, the plasma osmolality is high. Normally what happens is, if there is an increase in plasma osmolality, this will increase the ADH, which increases the water reabsorption in the kidney, and it reduces the plasma osmolality. This is normally. But here what has happened is, plasma osmolality is high, but urine is not concentrated. It is a dilute urine. So that means there is lack of ADH. There is no ADH being produced here. That is why when you give a synthetic ADH to this patient, he's able to produce a concentrated urine. Right? But of course, the question says, which segment of the nephron does the tubular fluid become the most dilute before hormone action? The answer is going to be the early DCT. Absolutely right. Absolutely. Yes, this is central diabetes insipidus. So just to complete the picture, what happens to the tubular fluid? Excellent. I'm so happy that you've been able to answer this question. Okay. The tubular fluid in the Bowman's capsule is isotonic. End of PCT also is isotonic. Yes, there is a lot of reabsorption in the PCT, but total solutes, total water absorption is to the same extent. So tubular fluid at the end of PCT is isotonic. In the descending thin segment, there is only absorption of water. So tubular fluid becomes hypertonic, concentrated at the tip of loop of Henle. In the thick ascending limb, there is absorption of only solutes, Na plus, K plus, 2Cl minus cotransport, and the absorption of solutes is much more than the absorption of water in the descending segment. So what will happen to fluid at the end of loop of Henle? This will become hypotonic. It will become dilute. As it passes through the early DCT, there is absorption of more sodium and chloride. There is going to be a further dilution. So it is going to be most dilute in the early DCT. After that, in the late DCT and in the collecting duct, hormones will now decide what is going to be the final composition of urine. This is known as the hormone regulated segment. What is the hormone regulated segment? Late DCT and the collecting duct. This is known as the hormone regulated segment. The relative concentration of ADH and aldosterone will determine what is going to be the final composition of urine. Right? So this is going to be late DCT and the collecting duct. Right? The answer to this question is early DCT. Absolutely right. Okay. All right, some one-liners. Okay, how much is normal GFR? This is 125 ml per minute, or you can write it as 180 liters per day. What is the formula for clearance? Formula for clearance is UV by P. U is the urinary concentration, V is the rate of urine flow, P is the plasma concentration. Maximum sodium, potassium, calcium chloride bicarbonate reabsorption occurs in the PCT, but maximum magnesium reabsorption is in the thick ascending limb. Extremely important. Only electrolyte which is absorbed maximally in the thick ascending limb is magnesium. Maximum glucose reabsorption occurs in the PCT, maximum water reabsorption in the PCT. Mechanism of sodium reabsorption in the PCT is a secondary active transport, secondary active co and counter transport. Mechanism of sodium reabsorption in the thick ascending limb is also a secondary active co-transport, Na plus, K plus, 2Cl minus co-transport. In the DCT, it is an Na plus Cl minus co-transport. Aldosterone will increase the sodium reabsorption in the collecting duct. Maximum H plus secretion, PCT, urine acidification occurs in the collecting duct. Right? So all these extremely important one-liners. Maximum glucose absorption PCT, maximum water reabsorption PCT. This question has been asked. Maximum ADH secretion is there. Even then, the maximum water reabsorption, 2/3 of the water reabsorption occurs in the PCT. Mechanism of sodium reabsorption in the PCT is a secondary active co-transport, sodium glucose co-transport, sodium phosphate co-transport, sodium amino acid co-transport, and a counter transport also. In thick ascending limb is also a secondary active co-transport, Na plus, K plus, 2Cl minus co-transport. A drug which acts on Na plus, K plus, 2Cl minus co-transport is Lasix. Loop diuretics. Mechanism of sodium reabsorption, the DCT, sodium chloride co-transport, a diuretic which acts on Na plus Cl minus co-transport, thiazides. Aldosterone increases sodium reabsorption and potassium secretion in the collecting duct. Yes, maximum H plus secretion, PCT, urine acidification, collecting duct. Yes, Samina, I will be giving you the PDF after the class. All right. A 56-year-old man presents with progressive shortness of breath, abdominal distension, bilateral leg swelling for the past 3 months. He has an elevated JVP with prominent V waves. There is a fluid overload here. Hepatomegaly with pulsations, pansystolic murmur, best heard at the lower left sternal border, that increases with inspiration. Which of the following is the most likely underlying abnormality causing this patient's JVP findings? There are prominent V waves. This is probably a tricuspid regurgitation. Tricuspid regurgitation. Let's have a look at this. JVP is always seen on the right side. Why right side? Because the right internal jugular vein is in direct communication with the right atrium. Any kind of pressure changes, communication with the right atrium. Any kind of changes in the right atrium will be reflected in the right internal jugular vein, which is seen as the JVP, jugular venous pulse. Where do you look for the internal jugular vein? It is between the two heads of the sternocleidomastoid. As you can see, there is a sternal head of sternocleidomastoid, there's a clavicular head. Between the two, you will have this is the internal jugular vein. Yes, as you can see over here, the internal jugular vein. Now, how do you measure the internal jugular, the JVP? You use two scales. Firstly, you have to put the patient at 45 degrees. Patient is at 45 degrees. This is so important. Yes, patient is at 45 degrees. You go to the right side, look at the right JVP, look at the upper level of the right JVP. Yes, place a scale horizontally. Yes, and place another scale vertically over the angle of Louis. What is angle of Louis? Angle of Louis is the angle between the manubrium and the body of the sternum. So let's say if this distance is 3 centimeters, you will add 5 centimeters. Why will you add the 5 centimeters? Because the distance from the angle of Louis to the center of the right atrium is 5 centimeters. So 3 plus 5 gives you 8 centimeters of water. This is not in millimeters of mercury. This is in centimeters of water, right? This is how you measure the JVP, right? Important features about the JVP. Police. P, palpable? No, it is not palpable. O, occlusion? Yes, it is readily occludable. L, location between the two heads of the sternocleidomastoid. I, what will happen with inspiration? The upper level of JVP falls with inspiration. If the upper level of JVP does not fall with respiration, with inspiration, or rises, that is known as the Kussmaul sign. Kussmaul is seen in constrictive pericarditis. Contour. There are multiple positive and multiple negative waves. Which are the positive waves? A, C, V, and which are the negative waves? X descent, Y descent. What happens in the erect posture? The upper level will fall and go behind the clavicle in the erect. That is why we put the patient at 45 degrees. Yes. JVP with the cardiac cycle. Let's just see this. JVP is very, very frequently asked. Onset of ventricular systole is the first heart sound. Onset of ventricular diastole is the second heart sound. Third heart sound is heard in the first rapid filling phase, and fourth heart sound, if present, will be in the second rapid filling phase. These are the heart sounds with the cardiac cycle. Remember, between S1 and S2 is your ventricular systole. Between S2 and the next S1 is your ventricular diastole. This is the ventricular systole here. between the first heart sound and the second heart sound. Between the second heart sound and the next first heart sound is your ventricular diastole. Right? Now JVP. A wave. A wave is due to atrial contraction. Atrial contraction occurs in the second rapid filling phase. So A wave of JVP will be recorded here. Second rapid filling phase. This is A wave. So A wave of the previous cycle is here. Then another positive wave which is called the C wave. C wave is due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction phase. Then in the phase of ejection, you get an X descent. What is X descent? In X descent, the atrium is relaxed. Atrial relaxation as well as a downward pull of the closed tricuspid valve causes the right atrium volume to increase and pressure to decrease. Then you get another positive wave which is called the V wave. V wave is due to venous filling of the right atrium just before opening of the tricuspid valve. At this point, the tricuspid valve opens. And now blood will go from the atrium into the ventricles, which gives rise to the Y descent. So Y descent will coincide with the third heart sound. A wave will coincide with the fourth heart sound. Right? So this is as far as your JVP with the cardiac cycle is concerned. Now, an important table. First is prominent A wave. How can the A wave become prominent? That means now the atrium is contracting with more force. This will be seen in tricuspid stenosis or in a decreased right ventricular compliance. Next is a cannon A wave. Cannon A wave is a very large A wave. See, normally when the right atrium contracts, the tricuspid valve is open, blood is going from the right atrium into the right ventricle. But in certain clinical conditions, when the right atrium contracts, the tricuspid valve is closed. So all the force of the right atrium will be reflected back and you see a cannon A wave. This is seen in what is known as the atrioventricular dissociation. This occurs in heart blocks. This occurs in what is known as junctional rhythm. Absent A wave. Absent A wave is in atrial fibrillation. A large V wave. V wave is due to venous filling. Normally, right atrium receives blood from the superior and the inferior vena cava. But in a tricuspid regurgitation, blood will also come from the right ventricle into the right atrium, regurgitate. So, large V wave. Sharp X plus absent or blunted Y plus pulsus paradoxus is seen in cardiac tamponade, a question which has been asked again and again. A sharp X plus sharp Y, which is known as the W sign or the M sign, this plus Kussmaul's is seen in constrictive pericarditis. I've already told you, Kussmaul's sign, what is Kussmaul's? Normally during inspiration, the upper level of JVP falls. If it does not fall or rises during inspiration, it is called Kussmaul's sign. So, extremely important table which has been asked again and again. You should be able to answer this now. Another one. A 60-year-old man with long-standing hypertension and atherosclerosis is found to have 50% narrowing of the lumen of his left renal artery on Doppler ultrasound. Renal blood flow through this artery is assessed under steady laminar flow conditions. It's like if there is a plastic pipe, water is flowing through it, put your foot, what will happen to flow? Flow will reduce, isn't it? What is Hagen-Poiseuille's law? Right? Hagen-Poiseuille's law states that Now, there are two very important formulae for blood flow that you must know. Flow is equal to delta P by R. What is delta P? Delta P is P1 minus P2. This is the pressure difference at the two ends of a tube, right? P1 has to be more than P2 for blood flow to occur. Divided by R is resistance to flow, right? Absolutely right. Now, R is resistance to flow. So, more the resistance to flow, less will be flow, right? Now, Hagen-Poiseuille's law states that R is equal to 8 neta L over pi R4. Neta is viscosity. More the viscosity of the blood, more the resistance to flow. L is length and R is radius. Resistance and radius, what is the relationship? Resistance is inverse to the fourth power of radius. So this formula of resistance, let's substitute in the first formula. First is flow is equal to delta P by R. So this says flow is equal to delta P into pi R4 over 8 neta L. In other words, flow is equal to pi by 8 into delta P R to the power 4 divided by neta L. So that means flow is directly proportional to the fourth power of radius. More the radius, more the flow. Have you understood? Less the radius, less the flow. Now, but remember, flow is directly proportional to fourth power of radius. The radius has now become half. It's a 50% narrowing. So it is going to be half to the power 4. In other words, it is going to become 1 upon 16. Absolutely right. Right? Because half to the power 4 means half into half into half into half. Right? So it will be 1 into 60. 1 upon 60. Take it? Okay. Dhanashri, have you understood this? Dhanashri? Okay. Blood vessels which contribute the maximum to resistance, systemic vascular resistance. This is going to be arterioles. Extremely important. Arterioles are known as your resistance vessels. The seat of, they are known as your resistance vessels. The seat of when I say total peripheral resistance, that means resistance at the level of the arterioles. Phase of cardiac cycle which follows the first heart sound will be systole. Heart sound which is associated with first rapid ventricular filling is the third heart sound, and third heart sound is associated with the Y descent. Which wave of ECG depicts the ventricular depolarization? QRS complex. P wave is atrial depolarization, QRS complex ventricular depolarization, T wave is ventricular repolarization. Which phase is not represented on the ECG? Atrial repolarization, because that merges with the ventricular, with the QRS complex. What is the normal resting cardiac output in an adult? It is 5 liters per minute. This is 5 liters per minute. It can, during exercise, it can increase by almost 4 to 5 times, 20 to 25 liters per minute. Where are the baroreceptors? Baroreceptors are your carotid sinus and aortic arch. Carotid sinus are located in the internal carotid artery, just above the bifurcation. Aortic arch baroreceptors are located along the arch of aorta. What are these baroreceptors? These are pressure receptors. They are stretch receptors. They will be stimulated when there is a stretch of the vessel wall, when the blood pressure rises. Then the baroreceptors will be stretched Baroreceptors will result in two things. They will decrease the sympathetic discharge and increase the parasympathetic discharge to the cardiovascular system. This is the stimulation of the whenever the blood pressure rises, there is more stretch of the vessel wall, baroreceptors will be excited. They cause a decrease in sympathetic and increase in parasympathetic discharge. What is the Bijold-Jarisch reflex? Bijold-Jarisch reflex, there is a question later on it. I will do that with you. Future you is watching you. Right? So it's important to put in all the hard work so that later in life there are no regrets. Yes? A 60-year-old patient complains of breathlessness on climbing. On auscultation, heart sounds are normal, normal breath sounds. Flow volume loop is shown in the color blue. Now this is a right shift of the loop. This is typically seen in a restrictive lung disease. In a restrictive lung disease, this is a parenchymal restrictive lung disease. Let's try and see what happens in the different types of. So in a obstructive lung disease, what is obstructive lung disease? These are normal flow volume loops that I'm making. Right? In obstructive lung disease, what is obstructive lung disease? COPD, asthma, isn't it? Bronchitis, emphysema. The loop becomes like this. This is the loop that you see in obstructive lung disease. Right? This is called a scooped out curve. This is seen in obstructive lung disease. In restrictive lung disease, due to parenchymal causes, the loop is something like this. This is restrictive parenchymal. We call it this is relatively a tall and narrow loop. Right? In a restrictive lung disease, due to extraparenchymal causes, what are the extraparenchymal causes? Extraparenchymal causes like kyphosis, scoliosis, right? Restrictive lung disease due to parenchymal causes. What are parenchymal causes? Interstitial lung disease, pulmonary fibrosis, right? This will be pulmonary fibrosis. Obstructive lung disease, for example, COPD, emphysema, right? Then restrictive lung disease due to extraparenchymal causes. Kyphosis, scoliosis. Guillain-Barré syndrome. This is what you get. We say that the loop lies within normal loop. Loop lies within normal loop, right? So 3 types I've already done. Obstructive lung disease, loop scooped out curve, tall and narrow loop in the case of restrictive parenchymal causes. Restrictive extraparenchymal causes, it loop lies within the normal loop, right? Then you have what is known as large airway obstruction. Large airway obstruction. Large airway obstruction could be due to, it is not the same thing as obstructive lung disease. Large airway obstruction could be due to foreign body, tumor, right? Now let's see what happens here. Now large airway obstruction can be fixed or variable. So if it is fixed, what does it look like? Now this is a normal loop. In large airway obstruction, which is fixed type, the loop becomes like this. It's called a box type of loop. Large airway obstruction, fixed type. When there are foreign bodies, tumors, large airways like the trachea or the bronchi are affected, right? So this is called box type. If it's a large airway obstruction, extrathoracic variable. It can be intrathoracic variable, it can be extrathoracic variable. So let's say if it is extrathoracic variable. What is extrathoracic? Extrathoracic means here, above the thorax, above the 6th tracheal ring, right? This is my normal loop here. Extrathoracic variable, it is like this. The curve, it is extrathoracic variable. Your expiration is almost normal. It's the inspiration which is flattened. Inspiratory curve is flattened. Remember, E for extrathoracic, E for expiration. Expiration is almost normal, but the inspiratory curve is flattened. Inspiratory curve is the lower curve, expiratory curve is above the x-axis here. What happens if there is an extrathoracic there is an intrathoracic variable? Let's try and see that. Okay. So we've done large airway obstruction. Fixed type, whether it's extrathoracic, intrathoracic, it's a box type of curve. If it's an extrathoracic variable, example of an extrathoracic variable, for example, vocal cord paralysis. This is extrathoracic. Vocal cords, extrathoracic means above the 6th tracheal ring. If it is intrathoracic variable, intrathoracic means below the 6th tracheal ring. That means there is some sort of obstruction below the 6th tracheal ring. Remember here, inspiration is normal. This is inspiratory curve, but the expiratory curve is flattened, right? Expiratory curve is flattened. If it's a fixed type of obstruction, both the curves are flattened, right? So this is intrathoracic variable obstruction. So I've done 6 types of loops with you. Any of these can be asked in your exam, as they have been asked earlier. Once again, scooped out curve, obstructive lung disease. Tall and narrow curve, rightward shift, restrictive lung disease, parenchymal cause. Loop lies within the normal loop, it is restrictive lung disease, extraparenchymal cause like kyphosis, scoliosis, Guillain-Barré syndrome, phrenic nerve palsy. Large airway obstruction, fixed type, box curve. Extrathoracic variable like vocal cord paralysis, expiration is normal, inspiratory curve is flattened. Intrathoracic variable, inspiration is normal, expiratory curve is flattened. For example, when there is a large when there is an intrathoracic extension of a large goiter. These must have been covered in medicine as well, but I've just revised them with you so that there is no problem. All right. Okay. A 68-year-old man with severe COPD presents with drowsiness and shortness of breath. Arterial blood gas shows this. What acid-base disorders is present? Now, acid-base disorders, you have to look at three things. Number one is the pH. Number two is the PaCO2. And number three is the plasma bicarbonate levels. These are the three things which will help you to determine the primary acid-base disorder. You have to remember Rome. If it's a respiratory cause, opposite. In a metabolic cause of acidosis or alkalosis, it is equal. What is respiratory opposite and metabolic equal? First, see the pH. A low pH and a high PaCO2 is a respiratory acidosis. A high pH and a low PaCO2 is a respiratory alkalosis, respiratory opposite. Right? Metabolic equal. Now, for metabolic, look at, now you first see pH. First see whether it's acidosis or alkalosis. Like for instance, we've seen the pH here. This is 7.2. This is definitely acidosis. Second, I saw PaCO2. It is high. How much is normal arterial CO2? 40. Right? This is 60. So this is high. That means it is a respiratory acidosis. Bicarbonate here is 26, normal is 24, only a very slight increase. So this is a respiratory acidosis. How do you see respiratory? First look at pH, then look at CO2. If pH is low, CO2 is elevated, like in this question, it's a respiratory acidosis. pH is high, PaCO2 is low, it is a respiratory alkalosis. Supposing PaCO2 is almost normal, then if it is a low pH and a low bicarbonate, that means it is a metabolic acidosis. If it's a high pH and high plasma bicarbonate, that means it is a metabolic alkalosis. How much is normal bicarbonate? 24. Right? How much is normal pH? 7.38 to 7.43. How much is normal PaCO2? 40 millimeters of mercury. How much is normal plasma bicarbonate? 24 milliequivalents per liter. Right? So this is how you're going to see what is a respiratory or a metabolic cause. Right? Now the second thing that you have to understand is, if the cause is respiratory, then the compensation is done by the kidney. If the cause is metabolic, then the compensation is done by the lungs. Right? Compensation will be done by, so remember this. Primary cause is respiratory. Like in this case, it's a respiratory acidosis. So compensation will be done by the kidney. How will the kidney compensate? It will increase the secretion of H+ and absorb more bicarbonate. Have you understood? Right? So as you can see over here, the bicarbonate is slightly increased. Instead of 24, it is 26. That means the kidney is trying to compensate. Right? Full compensation is when the pH comes back to normal. So pH is still not normal. We will not call it compensated respiratory acidosis. Raviraj, please understand. Compensated means pH has to come back to normal. pH is not yet normal. pH is still low here. It is still acidosis. Bicarbonate level has increased. Kidney is trying to compensate. Right? Have you understood? Compensation here has just started. Naveed Pradhan, very good. You've cleared your FMG. Congratulations. All right. Now look at this. Now a patient with severe diarrhea presents with an arterial blood gas showing decreased PaCO2. Which of the following is most likely to be seen in this patient? Now severe diarrhea, remember, for metabolic acidosis, the 2 Ds. Metabolic acidosis. Right? The 2 Ds. What are the 2 Ds? Diarrhea and diabetic ketoacidosis. This will cause a metabolic acidosis. So what happens in metabolic acidosis? There is going to be a low pH and a high bicarbonate. Right? Rome, respiratory opposite, and a low bicarbonate. Respiratory opposite, metabolic equal. Low pH, low bicarbonate. This is your metabolic acidosis. Yes? In metabolic acidosis, the compensation will be done by the lungs. So how do the lungs respond? Lungs will respond by increasing the rate and depth of ventilation. Rate and depth of ventilation, this is also known as Kussmaul's. I told you Kussmaul's respiration is seen in all cases of metabolic acidosis. So what will happen to the PCO2 levels? PCO2 levels will reduce, isn't it? Because when you hyperventilate, there is a CO2 washout. There is going to be increase in the rate and increase in the depth of ventilation. So it's a low pH, low bicarbonate, and because diarrhea causes hypochloremia. So this is going to be a not elevated chloride. Anshul, it is going to be a low pH, low bicarbonate, and a low chloride. It causes a hypochloremia. Right? Diarrhea will cause loss of chloride. So it causes a hypochloremic metabolic acidosis. Is it okay? Right? Oh, sorry. Sorry. I'll just correct myself over here, right? So when there is a severe diarrhea because of the like I said, it is going to cause a metabolic acidosis. Now, when there is loss of bicarbonate, there is going to be increase in chloride, not a decrease. So Anshul, you are correct. It is a hyperchloremic metabolic acidosis. Why? Because now let me try and explain why is this happening. Because there is loss of bicarbonate. Yes. Because diarrhea means there is loss of alkaline secretion, loss of bicarbonate. So chloride is retained. So it is a hyperchloremic metabolic acidosis. Absolutely right, Anshul. I'm sorry. I should have corrected myself at that point. So it is going to cause a hyperchloremic metabolic acidosis. Why is there going to be increase in chloride? Because diarrhea is causing a loss of alkaline secretions. When there is loss of alkaline secretions, that means a loss of base, isn't it? Most of your intestinal secretions are alkaline. So loss of base causes acidosis. And because there is loss of bicarbonate, there is going to be increase in the chloride reabsorption, causing a hyperchloremic metabolic acidosis. All right. So diarrhea will cause a hyperchloremic metabolic acidosis, renal tubular acidosis, pancreatic fistula, and acetazolamide use. Okay. Which of the following describes a phenomena in RBCs where bicarbonate ions are exchanged for chloride to maintain electrical neutrality? So what happens here is, now in the venous RBC, CO2 enters. CO2 will combine with water in the presence of carbonic anhydrase to form H2CO3, which splits into H plus and HCO3 minus. H plus is buffered by the hemoglobin in the RBC. Bicarbonate is exchanged for chloride. This is called the bicarbonate chloride exchange. This is also called chloride shift. Bicarbonate is moving out of the cells and chloride is moving into the cells. And what follows the movement of chloride is water. So RBC volume increases. The venous RBC is a plumper. It is fatter. So it's called the hamburger effect or the chloride shift. Right? Hamburger effect or the chloride shift. Okay, so this answer is going to be B. Absolutely right. A 28-year-old woman in her third trimester pregnancy presents with complaints of shortness of breath for the past few weeks. On examination, her vital signs are stable and oxygen saturation is normal. Which of the following acid-base disturbance best describes her condition? Sorry, what is this? She's in the third trimester of pregnancy. There is shortness of breath. So she's hyperventilating. Yes, the uterus is enlarged and she's hyperventilating. So what is it going to be? Please tell me. Oxygen saturation is normal. What acid-base disturbance best explains her condition? Hyperventilation could be in anxiety, in pregnancy. Yes, and when there is a hyperventilation, there is a CO2 washout. So this results in a respiratory alkalosis due to hyperventilation. Is that clear? Respiratory alkalosis due to hyperventilation. Other causes for respiratory alkalosis due to hyperventilation: high altitude, anxiety. Absolutely right. Absolutely right. Ravi Ranjan and Dhanashri. Absolutely right. Okay. A 55-year-old man presents with recurrent epigastric pain, chronic diarrhea, significant weight loss for the last 8 months. He has a history of multiple peptic ulcers that are refractory to proton pump inhibitors. Upper GI endoscopy reveals multiple ulcers in the duodenum and jejunum. Fasting gastrin levels are markedly elevated. Which hormone? Which of the following hormones is responsible for this patient's condition? Fasting gastrin levels are elevated, so there is going to be increase in the HCl secretion. There is an increase in the HCl secretion, which results in multiple peptic ulcers. Proton pump inhibitors are not affecting here because it's the gastrinoma, the gastrin secretion, which is going to be high. Very good. World Gaming. I have passed January 2026. Attended same evening time, attended your 25 most important questions. Yes, but these 25 most important questions will help you if you have revised your physiology. If you're attending, if you've not done your physiology and you're attending for the first time, then it becomes a little difficult to grasp. But go through it once again, once or twice, and then you'll be able to understand these topics also. Sometimes it happens that you've attended some other teacher's class, and then obviously you find it difficult to adjust to my style of teaching or my style of speaking sometimes, right? So it becomes, so then the only way is try and go through it once again. Okay. A 6-month-old infant is brought to the pediatric clinic with chronic watery diarrhea, abdominal distension, poor weight gain. Mother notes the stools are acidic and frothy. Symptoms improve when milk products are avoided. So this is a patient of lactose intolerance. Which most likely defect responsible for this child's condition? Yes, Ravi Raj, absolutely right. What is responsible for this? Milk products. If you avoid that, that means there is a deficiency of pancreatic lipase, right? Okay. Sorry, this is because of the symptoms improve when the milk products are avoided. So this is lactase, brush border lactase. Lactase is responsible for the digestion of lactose. Milk products are avoided, and this does not happen. So if it is a pancreatic lipase deficiency, then of course there will be a large volume of stools. There is a steatorrhea. Yes, this is C. C is the better answer. It has to be lactose, because lactose is not being digested. Yes, because like I said, the key word here is when milk products are avoided. Okay. Yes, C is the correct answer. Vishnu and Ravi Vyas. All right. Show up, revise, and repeat. That is the only way to success. There is no shortcut to success. The only way to be successful in this exam is a repeated revision, right? Repeated revision. So this is your end of your physiology 25 most important clinical questions, and I will share the PDF with you. Try and go through these important points. There are a lot of one-liners also which I have discussed, a lot of important questions, important topics which we have discussed today. But like I said, you have to repeat them. I will put up the PDF, send the PDF on your group, right? And so thank you very much and all the best. Any problems, please get in touch with me. You know where to reach me on all social media handles, Dr. Anupama Physiology. Yes, and I will try and answer your questions. Thank you very much. Thank you. Yes, thank you, Himalayan, Dr. Ankit, Abhijit, and Dervish. Thank you very much. It's Ridervish. I'm sorry, I think I'm not pronouncing it correctly. Jessica, thank you very much. Thank you.